Hello, and thank you for attending our special speaker presentation with Dr. Jenice Baker. I'm happy to introduce her. She was one of the key speakers at ACEP in Boston this year. Unfortunately, I was not able to attend her speech, her presentation, but luckily the people over at Diversity, Equity, and Inclusion have invited her to come speak to the entire university. Dr. Jenice Baker is the director and chair of emergency medicine at Chestnut Hill Hospital in Philadelphia. She has practiced community emergency medicine for over a decade, providing compassionate clinical care, and was named top doc in 2018 and top emergency medicine specialist in 2020. In addition to practicing clinically, Dr. Baker advocates for New Jersey emergency physicians. She's also a fellow of the American College of Emergency Physicians, and in 2015 was elected board of directors for New Jersey ACEP and is currently the president-elect. Alongside advocacy, she's passionate about education and has given many presentations on various topics, including women leadership and violence in the emergency department. Dr. Baker is also a national speaker on provider biases, and medical racism. I'm pleased and honored to present Dr. Jenice Baker.
Thank you so much for having me here. I am very happy that someone was able to hear the talk at ACEP because I think it needs to be heard all around within our medical spaces and particularly in our education. So today I'll be talking about racial perspectives on the institution of medicine and really kind of specifically how racism entered medicine and maybe ways that we can think about ways of handling or tackling this issue of racial disparities within the House of Medicine. So I do have disclosures. I am a consultant for Bristol Myers Squibb on venous thromboembolism management, and that should not impact this talk today. So we all operate within this realm of healthcare. And depending as you are a university at Iowa, there are many different varying stages from medical students to residents to attendings, community hospitals like I work in. And our main goal is to provide care to our patients, to the community. We use the platform of our hospitals to do that, and sometimes even our clinics or outpatient areas. And we also have to kind of communicate with our payers and understanding insurances and kind of navigate this whole world of healthcare. And what was very interesting with COVID-19, which is now going its 2 years into this COVID pandemic, it really impacted how we delivered care to our patients. Primarily as an emergency room physician, we did not know what to do. Did we have the right PPE? Which patients should come to the emergency room? Which patients should stay home? But particularly early on in the pandemic, if we can think back to 2 years ago, we really had people isolate so that they did not get sick, that they did not get risk for exposures because of the overwhelming stress that COVID-19 patients that were admitted took on the healthcare system and in our ICUs. What we also saw with COVID, though, which was very interesting, was the impacts of medical racism or just even disparities in care, where we saw early on in the pandemic that racial minorities were more likely to contract COVID as well as die from COVID. The disparities is not as stark now. Now it's 2 times more likely to die of COVID for African Americans early on in the pandemic, 3 times, but the disparity was still there. But part of the reason that this, I think, topic has taken off now is that we were all in isolation and all watching our screens. And not only were we seeing these disparities happening in medicine, we saw with the death of George Floyd nationally on the screens, we could see signs of institutional racism play out in different realms. We saw it play out in law enforcement, and with COVID, we definitely saw it play out in our emergency departments and in our hospitals. So what I'd like to do is sort of give a historical context and sort of go down historically how racism has entered into the House of Medicine to help lead to some of these disparities that we see today and even now as we are going through a pandemic. So I may ask some of you on to talk. Oh, this is an important slide. Before we move on, this is actually very critical. I would say how I was taught in medical school. You know, you get information and you learn. And even in science, we understand that things may change. we accept some sort of scientific humility that the way that we've practiced in the past, what we've learned, can change depending on the data and information that we have currently. And I would like all of us that's listening to this talk or who will be listening to also apply that to understanding the social implications of this talk, because this can be a difficult talk. But I think what's very important in order to have this talk is cultural humility, which incorporates a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-physician dynamic, and to developing mutual beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and defined populations. And this concept was actually coined by physicians when they realized they wanted to think of a way of better taking care of their patients. And it goes beyond cultural competence, because we cannot become competent and all-knowing for one certain culture, but actually having the humility to put what you think is your norm to the side and being able to take on a different viewpoint. So for this talk, I'm asking that all of us take a conscious effort to have cultural humility. And this is a cartoon that kind of just talks about, an idea of the cultural humility here. Has it ever occurred to you that you might be wrong? And I want us to just think about a different perspective. Maybe the way that you've always thought about things is not the way that it may be for someone else in that situation. So I went on your website, and this was a picture listed for graduates, for medical students graduating. And I put this slide up because I wanted to ask, and if anyone wants to unmute, I may not be able to see the chat box, but someone can read it out. When was the first time that you heard race mentioned in your realm of education, medical school residency? When was the first time that you heard race mentioned, and how was it mentioned? For me, it was very clearly in the patient history. And this is going back many years ago. In medical school, you'd hear, if they were describing me, it would be a 43-year-old Black woman presents with XYZ, could be chest pain, abdominal pain, could be ear pain. And in that first line of a patient history, we give certain information so that myself and my colleagues as physicians can start strategizing and start figuring out what complaints the patient may have and where that may fall out in clinically working them up. Age, if I'm dealing with a child versus I'm dealing with an older patient, concerns for RSV or croup versus concerns for stroke or dementia-related concerns. We can give sex if it's a woman with abdominal pain. Is she pregnant? Is this an ectopic pregnancy? Is this a man who's having testicular pain and I have to be concerned of testicular torsion? And we give race. And race is important because if we look at our history, or even if we look at our demographics first within the United States, being a minority puts you at risk for every disease process, from cancers, all types of cancers, hypertension, diabetes, strokes, renal disease, all medical illnesses. But when we mention it in that first sentence with age and sex, it may be understood or comprehended as a biological factor, something that is immutable, doesn't and cannot change. But is that really the case? Is race a biological factor? The human genome was sequenced early 2000s. And after sequencing the genome, it's known that all of us share 99% of our DNA. And what was usually typically believed of having well-circumscribed genetic variations between races is not the case. So up top is what most people may think, based on what a phenotypic expression is, that it is aligned with certain genotypic traits. But it's not the case. There's a lot of variation, as you can see in the bottom, that goes in between. So race, we know, is more a social or a social construct, but there isn't any genetic or biological attachment to these physical phenotypes. But yet it is mentioned in the first line of our clinical presentations when we are trying to treat patients. And why is that? When did then this idea of actual race categories enter into House of Medicine? So this is Professor Dr. Robley Dungelson, and he is coined the father of human physiology. He was a personal physician of Thomas Jefferson, and he actually came over from England to start the first medical school in the United States. And this was in the 1800s, 1830s time period. He's the father of human physiology. So all physicians who are now getting training in the United States literally are reading his book and learning physiology from him. And in his textbook of human physiology, he stated, this race, and talking about anyone that looked like me, is evidently of a less perfect organization than the last, and have some characteristics that approximate it more to the monkey kind. And this was written in the medical textbook of the future doctors. He went on in his textbooks to have images because it was very important to understand the phenotypic differences between races. And beyond the physical depictions, it was important to understand the race mixing of blood, because again, of these racial inferiority beliefs that were supported by the medical institutions at this time. Now, what's very interesting is you have to think about what else is going on at this time as science is being taught to future doctors and human physiology textbooks are being written. What else is going on socially that's impacting the science? Does anyone want to venture or say or put in the chat, what else is going on in the 1800s where the scientific community is actually supporting another sort of industry that's going on at this time? Oh, eugenics is great, and we'll get into that into the 1900s. But prior to eugenics, but that also exactly led to even the idea of eugenics, is slavery. And so we want to think about that because what's happening in society, and I'm talking to a social medicine group right now, impacts our medicine. We like to think in the House of Medicine or as scientists that we can be completely objective. But I think it is very important to understand how the environment in which you are learning and practicing can impact the science that you are conducting and believing. So here we have the medical institutions supporting slavery by stating medically there are inferior characteristics, and they wrote it in textbooks, so it must be true. This was also propagated by other individuals that we've learned about and even read about as we went to medical school. But Dr. Anton van Leeuwenhoek, father of microscopy, Marcello Malfighi, father of histology, and Dr. James Sims, father of modern gynecology, which some procedures are being done today, also done on slave women, all of their beliefs with racial inferiorities, but they lay the foundation for our practice of medicine. And this was not always taught in medical school, was not taught when I went to medical school. We also had physicians, Dr. Samuel Cartwright, who was the head of the Louisiana Medical Association, and he came up with this diagnosis of drapetomania. And this is a disease, a psychological disease that a slave would have if they tried to escape captivity. So if they ran away or tried to run away and escape, something had to be wrong with them because the minds of slaves were morally decrepit and they needed to have a master. So if you decided to run away, escape bondage, escape whippings, escape being separated from your family, you had a mental disease that was classified in the DSM-4 as drapetomania. And the treatment for drapetomania was to whip the devil out of them. So you're whipping their back until literally they pass out, and that would be the devil whipping out of them, or to break their first toes on both feet so they could not physically run away. And I think it's important to understand the history because this is what a physician, just like I am, propagated and said and believed and was carried on. And here we again see another example of how what's going on socially impacts the medicine that is practiced. There were also other slavery time diseases that were coined at this time, and therefore slaves treated differently than white counterparts, like typhoid pneumonia, a more severe pneumonia, and saying particular to Negroes and inferring that it is due to some sort of genetic inferiority and not for the fact that they had much poorer, deplorable conditions and situations and not getting any sort of care and doing backbreaking work. Or having cachexia africana, dirt eating, and the treatment was wire mask, but that was just due to a severe form of pica due to iron deficiency. Or struma africana, which is a severe form of tuberculosis, again, because of the conditions that they lived in and lack of care that they received. But terming them Negro diseases already sets up a platform for different levels of care and access for care in this country. So here, I just laid out some examples of racism in our medical education. But we also have examples of this within our medical associations. The AMA was founded in 1847, and even after the end of slavery in 1865, it continued to have discrimination or continued the practice of discrimination. This was extremely critical because during this time frame, in order for a physician to work at a hospital, they needed to be credentialed, they needed to be a member of a medical association. So Black physicians were not able to get credentialed to work in hospitals. This is why the National Medical Association was founded. So Black physicians would have a medical association that they can gain membership to and therefore gain credentialing for hospitals. In 1910, Abraham Flexner, who was a representative of the AMA, commissioned a medical school report. And he wanted to go across the country and make sure that students being trained were receiving a standard education. So we can say that medical students in New York are getting the same education as medical students in the South, similar to ACGME and standards that we set today for our residents. But what's also interesting is that Abraham Flexner believed that the practice of the Negro doctor will be limited to his own race, which in its turn will be cared for better by good Negro physicians than by poor white ones. He also believed in this racial inferiority complex or racial inferiority belief of Black people. And during his medical school report, he closed all the Black medical colleges that there were at that time, except for Howard University and Meharry. Again, the AMA maintained discrimination even after the end of slavery. And so did many medical colleges and medical colleges. So the only way for there to be Black doctors was for Black colleges to teach them and Black medical schools to teach them. Closing these schools led to decreased availability to have doctors that looked like the patients that are already getting substandard care. So here we can already see the groundworks that lay into a differential access of Black physicians to take care of patients. And this is from the American Medical Association. After the end of slavery in 1865, from 1870s to 1865, there were many Jim Crow laws that were passed by legislatures of different states in order to still maintain legal discrimination and therefore a benefit for white people versus Black people. And if I think about Jim Crow laws or how I understood them before understanding the medical side, I would think about it as not being able to sit in the front of the bus, not being able to be served at a restaurant counter or using a different bathroom or different water fountain. But what's very important to understand is that it affected medicine and access to care and treatment in medicine. There was legal segregation in hospitals, such that white patients and Black patients could not be on the same floor. And in some hospitals, Black patients had to be treated in the basements and white patients on the first floor. There was separate but unequal care because of this. There were laws in certain states that white nurses could not nurse in a hospital with Black men. So if those Black men are patients, those Black men are visitors, those Black men work in a hospital, a nurse cannot practice there. And we've already talked about differential access even to education. If you have any hospital that has Black patients, you're going to have less staff available to care for you. And there were laws that said that all white patients had to be treated first before Black patients. In that critical hour of trauma, in that time, critical first hours for sepsis resuscitation, we understand that it's more important to treat a patient who clinically needs that care first. But literally, a doctor would be breaking the law if they treated a Black patient before a white patient. So understanding how our legislature has also impacted access to care, the type of care that can be given, and laying the foundations for why even today we continue to have disparities in healthcare. And then we can even talk about research. And this is just one of the studies that's well known. These are actual participants from the Tuskegee syphilis study. And this study was commissioned in order to study the life cycle of syphilis in 1932 by the US Public Service, so government funded. Penicillin was found as a treatable cause, easy medication to treat syphilis, and it was withheld from these men. And these men were still told that they were being treated for syphilis when they were not, and they were able to pass it on to their loved ones to their children, and to die awful sequelae with neurosyphilis and tertiary syphilis. But if you go back and try to find out why did the life cycle of syphilis why did we want to study that in Black men? The basis for that study was actually laid by a paper by Dr. Thomas Murrow in JAMA in 1910. And he postulated that neurosyphilis would be worse in Black patients versus white patients because of their freedom from slavery, their emancipation, that they would have a moral degradation of their minds because they don't have a master, that the spirochete would infect their brains more because their brains are inferior to white people's brains. And the spirochete will also therefore infect the cardiovascular systems of whites more because their brains are so much more advanced. And this is the paper that led the foundation to doing the US public study. This is one example of racism, but also of using African Americans as unwilling subjects in research in this country. And another way of how racism has entered not only our education, not only our medical associations, not only our legal laws, but also our research, which is the basis for the science and changing the science for how we practice. And this man is Mr. Richard Buxton. And what's interesting is he came over, his family were refugees from Yugoslavia after World War II, and they came over. And he started working at the US Public Service System. And when he saw that this study was going on, he filed complaints multiple times, and they were ignored. They did not listen to him. And it was only then when he told the story to the New York Post and then to the New York Times that the scandal was released about the US syphilis study, and then the study was stopped. And I put him in here because this is why it's so important to be able to have people to speak up against things that they see that is not right. And what's interesting is he had that comparison of Nazi control in his country and fleeing for that persecution, but then coming to another country and seeing it happen in a different level and being able to speak up about it. And I think it's important to realize that's why we need our allies, and that is why it's so important that if someone who has power or who has ability or agency notices something is not right, to speak up. Also in this country, we had forced sterilizations that happened to many incarcerated women, mostly poor, mostly minority women, and in some cases, not women at all, just children at 14 that were not told what were done to them when they were incarcerated. So other examples of just disparate care given to certain populations of women. So if we open up our textbooks today, we surely will not see the racist words of Dr. Robley Dungelson. We don't see that written, but we still can see a lot of effects of our history playing out today with racial healthcare disparities. And that is because of the implicit bias that this history has laid down. Implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. Perhaps some of the ways that we do our studies, the ways that we talk about our patients, like the 43-year-old Black woman comes in with, implicitly, we are condoning these beliefs and not understanding why. But that can lead to institutional racism because there have been policies and practices developed over time and procedures of institutions that have a disproportionately negative effect on racial minorities' access to and quality of goods, services, and opportunities. And how do we see that play out in the House of Medicine? In 2002, the Institute of Medicine did a minority healthcare report, and these disparities they found are still present today. They found that there are disparities in the healthcare delivered to racial and ethnic minorities are real. And what's interesting is even after they accounted for socioeconomic status, age, sex, and severity of disease, they found these disparities still exist and is in part due to the bias or prejudice of their providers, of people like me, because I am a provider. And what they found is that minorities were less likely to get they were more likely to get less routine medical procedures, less likely prescribed appropriate cardiac medications, less likely to undergo cardiac bypass, less likely to receive dialysis and transplants, and more likely to experience maternal infant morbidity and mortality. And this is what's happening with our patients that we're taking care of right now. So I've kind of talked about explicit racism from the 1800s, especially with slavery going on, and that creating institutional racism with our policies, procedures, our medical associations, our laws, our research techniques. That leads to implicit bias on part of our providers, and then it leads to the healthcare disparities that we see today. And how do we see that playing out? This is a study talking about implicit bias among physicians and its prediction on thrombolysis decisions for Black and white patients. And they found that specifically for those individuals who scored high on the IAT or implicit association testing, they had a high implicit bias for pro-white, those physicians were less likely to recommend thrombolysis for Black patients and particularly for Black women. A study by Hoffman et al. At Yale also looked at racial bias in pain assessment and treatment recommendations and found that if there were more false beliefs held about Black patients, they were less likely to treat pain in that patient presenting with kidney stones. And some of these false beliefs were held by first-year medical students, second years, third years, and then residents, such like Blacks age more slowly than whites, or Blacks' nerves endings are less sensitive than whites. And the more likely that these were believed, the less likely they were to treat those Black patients adequately with pain medications. So this is how it is impacting our current care today. So what do we have to do? How do we start to tackle that? We have to start with education, and talks like this is the first pillar, where we're able then to go to ACGME and make sure that it's not about cultural competence or one class, but continued learning, understanding. And it is going to be a process. It's not a quick, easy answer, but understanding that these disparities occur, understanding what caused these disparities, and then talking about research or ways or interventions to deal with these disparities. We have to talk about race, but we have to talk about it as a social determinant of health and taking it outside of the biological category, because it does impact how long you'll live, where you'll go to school, money and income based on your skin color, and also based geographically of where you live. We have to actually identify racism as a public health crisis, as the current CDC director has done, and putting it in its correct box, and not that, oh, well, because this person's Black, they have these medical problems, we can't deal with it. But understanding that it's actually a signal, a sign of a racism socially. And that means we have a role to play. And we as physicians, we as healthcare providers can impact that. And we actively may be the problem. We need to have unconscious bias training for health professionals, and to do that for medical students in the training now, nursing students in training now, but also for those who've been out of training for a while like myself, because the education that we received when we were in training is very different. We have our CMEs. This needs to be part of our standardized CMEs. We need to start thinking about it and how we actually apply medicine. Race is used many, many times within our race calculators or within our clinical calculators to help us determine and stratify patients for care, particularly the GFR correction that's used within our calculation for creatinine function. And African Americans get a higher number. That delays the time when they see a nephrologist and increases the likelihood that when they do, they are at the need for renal transplants. And this is all based on faulty studies. So we have to look at how we're using race in clinical calculators and using race, again, here as a proxy for biology and genetics and making our care treatment plans based on that when race is a social construct. And even using these calculators, we may be thereby further making the racial disparities more, even though we've known about it since 2002. And this graphic is important. The other part we need to do is being able to talk about racism, and not only about provider bias that I've been talking about here so far, but even about patient bias. This is a graphic where it says, the patient called me colored girl. The senior doctor training me said nothing. Silence speaks volumes. How are we training and teaching our medical students, our residents, our providers, our attendings, those in training, nurses, providers, to talk about racism? Do we train individuals in how to address racism? Do we know even what the policies are at our institutions in order to address this? And these are the conversations that we have to start having, because with provider bias, there is also patient bias. And what's interesting about that is it makes a difference. This is a study that looked at medical school experiences associated with a change in implicit racial bias among medical students. They had medical students first years take their implicit association testing, the bias test, IAT, and then they had different clinical education to teach about implicit bias. But what they found, and they retested them later at their fourth year, but what they found is that the actual experiences that these students had with their senior residents, with their faculty, was more associated with changes. For instance, if a senior doctor says, yeah, those people usually are extra with their expression of pain, talking about a certain group of patients, that more so affected the medical students' experience and whether or not their implicit bias increased or decreased. So again, this is why we need to train those who are training the new students, not just the students coming in now who may have a different inkling, a different society milieu growing up now with what we're dealing with George Floyd and being in the 21st century than when some of us trained, because our ideas and what you believe can still impact those in training today. We obviously need to increase diversity in medicine. So this is a picture of my graduating school class, and this was in 2004. And there were only 5 Black people in my class of 100, so about 5%. And what's interesting is if you look at the data for matriculation by race, it's been about the same since after 1960s with civil rights movements and such, after ending those Jim Crow laws. You see it's about the same for African Americans. Part of this also is lack of availability and access with the medical schools that were closed by the Abraham Flexner report. But what's interesting that now, in the most recent data, the numbers are about the same, 7%, 6%, and it's not reflective of the population. And this is also important because there have been studies that show that race concordance between provider and patient lead to increased compliance. So why is that? Then we can look at what the acceptance rates are, what's going on within our recruitment process, our admission process for medical school. And overall, it's about a 40% chance of getting into medical school acceptance rate across the board, except for African Americans, where it's about 10% less. So this is where we get into institutional racism, where you may have policies and procedures that are set by which it already excludes one group. And this is something that we have to look at, especially if we want to increase diversity in medicine, increase diversity of our providers. Now here I like to talk about how I got into talking about racism in medicine. And it was this article that I wrote many years ago. And here it was talking about a patient who came in, single doc coverage in a community hospital. And we got a notification that an elderly woman coming in, combative, confused, low blood pressure was coming in. So we thought she was septic and the team is preparing for her. When she comes into the room, the team's getting ready, putting IVs and putting her on the monitor. And I come in and introduce myself as Dr. Baker. And she says, "Get away from me, you Black person." So what do we do when we have to deal with patient bias? And there was a study done by Web Focus and others that looked at patient prejudice. And this is something else, particularly for emergency medicine, and that is my specialty, that we deal with. And in this study that they asked physicians what type of bias they heard the most about, it was about age, mainly ethnicity, and then gender. And about almost 60% heard an offensive remark about their personal characteristics from a patient. But if we break down how many of the physicians who heard those comments, the majority of them were African-American, Asian, and then Hispanic. The majority in emergency medicine, and that's usually because when someone's having an emergency or has to go to the emergency department, they don't get to choose their provider. But what's interesting is, are institutions prepared to handle the bias? 60% of the physicians didn't know if there was a formal process, and 85 said that their institution didn't provide training. So we need to have education not only about talking about the history of racism in medicine, understanding we have implicit bias, doing research and figuring out ways to tackle that bias, but also from an institutional standpoint, have training and letting our staff and employees and students and everyone know what you actually do when you encounter bias and racism. What is your policy? And this is just an example of the policy that we have at my hospital. But I think this is something that's so important because you have to train and prepare, just like we do in medical school. Train and prepare for when you experience patient bias, how to handle it. Otherwise, you won't know what to do. Other things, tools that can be used to help with this type of work and this discussion is to have perspective taking and understanding, again, similarly to the cultural humility that I asked you to have earlier, that two people in the same situation can see something differently. And having perspective taking, particularly when you're one-on-one with a patient in a room and you feel that the communication isn't going well, to stop and try to see things from their perspective, or to have them try to explain it and let them talk uninterrupted. And these can be some sort of tools to help with your own personal clinical experience or interactions with patients. Also, to set goals. These goals specifically for D&I can be set on the institutional level, the program level, and then the individual level for a clinician or student in training. And therefore holding yourself accountable and then coming back to these goals. But the biggest thing is to talk about the elephant in the room, to talk about racism in medicine, because once we can identify the problem, once we can diagnose it, then we can work towards treatment. And making sure that it is not taboo to talk about it so we can move beyond it. Again, I ask that you have cultural humility because we all have our implicit biases. We all have different cultural beliefs that we were brought up with. And so this work may not be easy, but it is necessary if we are going to impact the care of our patients, but also improve the workplaces with who we work with every day. And thank you. That is the end of my talk. So any questions?
That was amazing. Thank you so much. I wanted to point out when you asked, when were you first exposed to race in medicine? I also graduated in 2015 on that from Howard. And even at Howard, we were a 40-year-old Black female, et cetera, et cetera. And that was at Howard.
Yeah, that's a great point you bring up. I think people may assume that for implicit bias or the implicit associate testing, and everyone can take that test. It's a free, it was developed at Harvard, is that you can be a Black person and still be pro-white bias because it's based on the society that you live in. And most people are pro-white bias just based on white privilege, the messaging, the psychology of things that we've seen and in this country particularly. So it's great to your point that that was something that was done and said. And it's interesting because you'll say, 43-year-old Black woman, not necessarily 50-year-old white man. It will just be 50-year-old guy comes in with chest pain and really understanding. And I've had different medical students. I gave this talk at a FemEM a few years ago, and there were students who were rotating from Canada and Australia. And they were like, why do you guys say that? We don't do that. So it was just very interesting when you have different perspectives and taking that on and understanding where that came from.
Also, I found I'm the social EM fellow here. When reading, of course, research articles on race and so forth, they'll say, oh, Black people have higher rates of heart disease, of such and such. I get wondering, what is considered Black? If you're half white, half Black, do you fall into that category? Or
there are so many questions that go into that because it's based on when the patient registers. Are you asking the patient to self-identify? Is the registrar or the person identifying the patient? What happens if nothing is filled in? And so that's exactly right. What is that idea? But that therefore goes again into that whole idea within the human physiology book, where it was important to even denote if you were 1/64th Black, right? There's not a biological reason for it. It's a social, reason for it. And then, but if you list it like that, well, you're Black, that's why you have high blood pressure. There's nothing I can do about you being Black. You just have it. Versus, well, there are things that I can do about it, right? Let's look at the environment. Let's look at what you're eating. Let's look at what your access to education there, food literacy there. It's a very complex issue, right? And it's harder to actually deal with and tackle than just being able to say, well, you're Black and you have high blood pressure. But then you're right. What does your Black even mean there? And similarly, what does your white even mean?
it's a safe space.
I'm okay with the quiet. Some people may take their time or ask later. It's okay.
Yeah. Dr. Baker, I had a kind of one question about, you mentioned a little bit some of the distrust that some of the various populations have in healthcare. Are there ways that you have found that healthcare in general has been trying to mend some of those relationships, like within the community on a whole, or what is the strategy that is used to kind of mend that?
Where we are now, I think, and again, because this racism issue applies to every industry or sector, and particularly with George Floyd, isolation, we're in that sort of social movement sort of now. I think this is a time to understand how. So I think overall, a lot of medical institutions, medical centers, they've all kind of published D&I statements, mission statements, understanding. But I think the next part is even education on, and this is something I want to work on, I don't know when I'll have time to work on, is how to talk to patients about race, right? Not about racism, because I know it exists, but how to talk about race, given that we all are trauma. We all have experienced trauma and it's trauma triggering. I think one of the first things is on the individual relationship with the doctor. And just like we go through social history and we've all been taught to ask, do you use drugs? Do you smoke? What type of sexual intercourse do you have? And we all are trained to say, this is just so that we could take adequate care for you. We could also say, how do you identify yourself? By I guess we could say, by if looking at you, you may be considered in this racial category. We have a history of racism in this country against people that may look like you. And this may have added extra stress and burden to you living, not only medically in all these other ways, but that can also add stress to our relationship. I want to acknowledge that and let you know that I am aware of that as a provider. And so when we are having this shared communication and decision-making. If there's ever a time that you think that I am discussing something with you and not taking you fully into consideration and all of your experiences into consideration, please stop me and let me know. Or, or you could create whatever safe word. But I think a lot of the issues are lack of acknowledgement of it. And if you don't acknowledge the actual problem, how is someone supposed to then trust you now later on when you say, I think this is what you need to do? I think that's a lot of it is acknowledgement, but also being comfortable with that conversation. That is not something that someone who may think, oh, well, I may have privilege. I may come from a background of privilege. How could I say this? I'm already seen as the enemy. How can I walk into this room and treat this patient? This is a process, and learning skills, learning tools, self-awareness, that cultural humility, and understanding it is trauma-filled, and you may get someone who's angry, who rightfully should be angry. But I don't think it's not going to necessarily be an easy fix, but I think it's definitely conversations, but training in the conversations, but first learning the history and understanding it. A lot of the things I've talked about here, many people have never learned about. And so they don't even know that that exists, and that's adding to this problem. They may understand it from a iceberg, just the tip of the iceberg, but all these things are still happening, applying now, like NFL having race correction for Black players with concussive symptoms afterwards and not getting payouts. Black patients were scored higher when they did their dementia. They got extra points when they did their dementia scoring. So therefore they scored higher, so they didn't qualify for payouts versus white football players. This just happened. Like it's so implicit. So, I think there's a lot of acknowledgement that needs to happen, a lot of education that needs to happen. And then talking about how we have this open conversation. I think we probably need to include the community in the dialogue. How do you want me to talk to you about that?
Thank you.
There's a question in the chat that says, can you share your thoughts on the best way to intervene as an attending when trainees are exposed to discrimination? It seems challenging to balance addressing the situation against putting the trainee in an uncomfortable situation they may not have wanted to deal with. So I think that that's a great question, and it depends on, I guess, each circumstance. If the attending or the faculty member is in the room at the same time when they are seeing this discrimination, I think that is the adequate time to say, this institution has a policy against discrimination, and the way that you spoke to this doctor in training, nurse in training, is not acceptable. Granted, and I'm an ER doc, as long as they are not, ABCs are taken care of. We're going to step out of the room to diffuse the situation and come back at a later time. I think that's a big thing, to diffuse situations. Everything does not need to be handled immediately at that time. If it is something that these student or trainee experience and there was not anyone there to intervene, once they come out and to tell you that, I think that you have to give them time to process it. I think it does need to be documented and filed. That's the way that we can improve. I think that not having to put that trainee back in that room or such with that patient if they don't feel comfortable is not the right thing. But similarly, then the attending goes into the room and still addresses the behavior that was done. Part of that Medscape study that I showed at the end, I didn't include the slide. Sometimes they asked a question about what is done when a patient asks for another provider, right? They don't want this provider, they want another provider, right? And it actually said that in clinic settings and outpatient settings, like office, not hospital ED, a lot of times that the providers would just acquiesce to the request. And I think it's very important. That might be easiest to do, but to really address the reason on why they want the request. Because if the request is wanted based solely on discriminatory reasons, I just want a white doctor, I don't want a Black doctor, versus there may be cultural, there may be experiences to actually get to the reason why, then if your policy is not to allow discrimination, you have to say we cannot abide by that. And I think it's very important to address it to the patient. It can be addressed to the patient. It can be addressed calmly to the patient. And but it needs to be addressed because we have to be able to hold everyone accountable for their actions. So we're holding ourselves as providers by learning about our role in this, but we need to hold our patients accountable as well. And if you don't, and I think part of this is getting the education, finding out what are the policies at your institution for dealing with racism and discrimination and how. It usually has a policy stating we don't tolerate this. But if you talk to your HR representatives, there's actually detailed ways. Sometimes they actually give you scripting and wording to use specifically if you do not have the words yourself to use. So I think that that's always helpful to do, and always having a witness or someone else go into the room with you is always helpful, not to enter the room on your own.
Thank you, Dr. Baker. Yeah, we are actually as an institution working on policies directly related to patient harassment or misconduct that directly comes from the patient based on an individual's identity. Mm-hmm. So yeah, thank you. I think Dr. Suraju, did you have a question as well? I don't know if you can unmute. Okay.
Yes, I did. Thank you very much for a great talk, Dr. Baker.
Yeah, thank you.
I was just curious. So in the COVID era, I imagine some additional adaptations are necessary from an institutional standpoint to address systemic bias. I don't know if there is something that you've seen that have been well done by other places, or that institutions should strive to do in the COVID era to address bias.
Yeah, it's, I'm sure you guys are feeling strained, just like we are currently with the surge, and there's no isolation anymore, so the volumes are just crazy. I can talk experience from my institution. One of the things that we tried to do within the COVID era, our area did not have many outpatient infusion centers, at least for bamlanivimab for, the first variants. I know it's not effective now with our Omicron variant, but we didn't have an outpatient setting to offer this, and we didn't have infusion centers, so we decided to do it within the emergency department, right? But what's interesting is who's going to get that treatment, and are you going to be sure that you're giving it to patients who are actually more at risk, right? Or are you going to give it? Will doctors be choosing who to say to send this patient in for this treatment versus others? So we made it very clear that if anyone comes in meeting any of this criteria, they can get this medication. It is not just based on the will of the outpatient doctor sending in. And I think that was very important because sometimes if a patient came in and they tested positive, but maybe they didn't get the vaccine, they might have been hesitant sometimes to say, well, they didn't want the vaccine, they won't want that. No, you have to ask the patient, would you like that treatment? Similarly, we've gone past the stigma for HIV or STD training. We see patients coming in all the time for that, and we offer them the training. We never say, well, you're not using protection, so why would you want the treatment, right? But I think with COVID, it's very hard because this is a new pandemic. We also have empathy fatigue. We have coworkers that are extremely burnt out, and just even hearing the thought of perhaps someone not being vaccinated can trigger people. So I did a lot with our team to say, making sure it's applied evenly and acknowledging that you're being triggered. I understand you're being traumatized, but the treatment is separate than the patient's choice earlier on with coming in. And then later on, when our EDs became overrun with every patient, we did not have time nor space to give an outpatient treatment. We had to stop giving the monoclonal antibodies. And what was interesting is outpatient provider says, well, if I still send my patient in, can they still get it? And I said, no, we're not doing differential care, right? What you're trying to say now is set up a different standard where if I have a patient, if I have a doctor, provider, and then this doctor knows someone else in the hospital, they can come in and get a treatment. And someone else who doesn't, but still has the disease process won't. And if we go through the demographics and the backgrounds, it's more likely minority patients may not have a primary care doctor that will call someone in the hospital to set it up versus a white patient may have that, more likely in this country to have that connection. So I said we have to be sort of even in how we're giving access or denying access to something. And so we decided not to do it for any patient at all. But that took some feedback to kind of explain the reasoning why, because it's like, well, my patient can, but I had to talk about the other patients that are not. I don't know if that fully answered it. I don't know if anything broad spectrum from other emergency departments in the face of COVID, as we're all just trying to just deal with COVID.
Certainly. Thank you very much.
So the question in the chat says, I'm curious, what changes, supports has your institution made that has moved the needle in a positive direction? What bureaucratic roadblocks do you come up over against and over that you wish you could wish away? So I think that our institution has worked well with more so from as a community hospital, and working so much more with our staff, trying to create a diverse and inclusive hospital team, staff, and employees. So not necessarily from the medical education standpoint, but more on the community hospital standpoint. And we've been working a lot. We did a survey, and particularly what people talked about was education, but also transparency. I think there may be things that different groups are doing, but no one actually knows what's happening, and meaning environmental doesn't know what's happening, food services doesn't know what's happening. All of these individuals don't know what's happening as far as D&I, but they all are impacted and affected by it. So making sure that you're using whichever mode of communication to actually show what you're doing, showing the results of the survey. So that's the first step that we've been doing with education and offering education, but showing it and showing what we're doing and giving them access to it. Roadblocks is always money, competing, what I call which fire do you put out first? We're definitely in the middle of COVID. There are financial constraints. I would want to offer to make implicit bias training for everyone, sort of like your yearly annual compliance, and trying to get that done, because there are things that we institute that must be done, right? We have to do the sexual harassment. We have to do all these things yearly. We can easily put in also implicit bias course training, but developing the coursework, getting that done, maybe tailoring it for different departments, depending on what area you work in, that will cost money, and getting money, and then getting time also to work on it. I think the other issue that have to be wary or mindful about is sort of the minority tax, right? I am a Black woman, I'm a minority in this country, as well as I'm a physician, and this is work that I do. Is there anybody else on the team helping me do this work? And more particularly, are there white counterparts that can help? Because I think the other point is, it is not only for the work of the minority to do this work, it is really the work of everybody, so we can improve the care of everyone. But so those are just some of the things that I think that we've done, but some of the things that we wish we can kind of wish away.
Well, I guess that's time. It's almost 1 o'clock here, 2 o'clock your time. Thank you very much. The hype around ACEP was right. That was an awesome lecture. Appreciate
Thank you. Thank you. I was happy to present. You guys take care.
Thank you.
Thank you so much for your time. We really appreciate it.